Yes, right. Okay. Sure. Okay.
Hi, sir. We are going. Hi, sir. We are going live, sir. Can you hear now, sir?
Yeah, I'm able to hear.
Okay. So good evening, everyone. Today we have an interesting topic as regard to the heart and lung transplant. That is a donor lung harvesting from call to implantation. So for both surgeons and the pulmonologist, as you know, it's very important to select the right lung as soon as when we get a call from the from different hospital about the donor call. So many people are involved in this donor lung harvesting, right from surgeon, pulmonologist, perfusionist, everyone. So today we'll look about from a surgical point of view about how it happens right from the time we get a call to the time when we implant. So to speak about this topic, we have two experts as regard to the lung transplant from different parts of the country. One is Dr. Balasubramoniam. So sir is our surgical director of Department of Heart Lung Transplant from Yashoda Hospitals, Hyderabad. And another expert is Professor Ceulemans. So he was my mentor when during our training in Belgium, and he's a transplant and a thoracic surgeon in the University Hospital of Leuven. So Leuven is a place which does a lot of lung transplant, and his special area of interest is in LVRS, and also he's a part of Leuven Intestinal Failure and Transplant, and he is a head of the department of the lab of thoracic surgery and lung transplantation. So there are many different aspects or many good things that happens in the research lab as regard to the publication. A lot of EVLP work in rat lung transplants, etc. And I was also involved with him in many projects. So happy to welcome you, sir, for this presentation. Over to Dr. Balasubramoniam to start the presentation about the donor lung harvesting.
Yes, thank you, Vimi, and welcome to Dr. Lawrence. Hope I'm audible.
Yes, sir. Yes, sir.
Yes. So I'll be starting off my screen sharing. Yeah, are you able to see my screen?
No, sir. Screen, no, sir.
This one. This one. This one. This is the presentation.
Yeah.
Okay.
Okay. So you are able to see my screen now?
Yes. Yes, sir. Yes, sir.
Yeah, a second. Okay. So yeah, how do we take it out? Yes. So, evening, everybody. So, warm greetings from our Heart and Lung Transplant unit at Yashoda Hospital in Secunderabad. So, we are basically a group of 10 people who, more, in fact, I should say, who is focused on the lung transplant and are providing quality of care here at Yashoda Hospital in Secunderabad. Now, my topic for today is donor lung retrieval, how to assess our donor lung, and also how to do a size matching of the donor lung. Now, a small introduction about our heart and lung transplant unit. Now, we are actually a full-fledged thoracic surgery unit. We started off in 2019, and we performed around 1,000 thoracic surgeries for the last 4 years. We do around 70% of our work VATS or robotic. Now, COVID pandemic in 2020 spurred a lot of transplant activity and ECMO unit initiations in our country. Now, we also started our ECMO unit in May 2020. We had around 80 transfers for our ECMO unit during that pandemic time. And the longest duration was an ECMO COVID survivor who survived for around 185 days. So that eventually led to the starting of our lung transplant unit in October 2020. And as our first heart lung transplant recipient, here we operated him on Jan 2021. And since then, we have gone on to operate around 49 lung transplants over the next 2.5 years. Look at our cohort. Now, this is a cohort of 49 patients operated over 2.5 years. And as you can see, ILD forms around 62% of the patients we have operated on. CTD ILD, especially the scleroderma ILD group, we have operated around 3 of them. And with the challenges of associated esophageal abnormalities like an aperistaltic esophagus or a megaesophagus, GERD, Raynaud's phenomenon. Around six patients with bronchiectasis where the challenges were difficult explantation pneumotomy, more bleeding complications with higher transfusion requirements, post-COVID fibrosis, higher mortality we had in COVID fibrosis mainly because they tended to remain on ECMO even after transplant, and they had a higher incidence of sepsis when compared to the rest of the population. And surprisingly, no COPD referrals in our series and no primary pulmonary hypertension. Now, let's compare our series to the Vienna group. They are, of course, they are a long-standing program, 1,048 patients up to 2010, where we see that the number of COPD is there in their series is around 34% compared to nil in our series. The IPF IPF is around 19% in their series, while it is around 62% in ours. So that's what's different when we compare our cohort to the European or the US cohort. Now, we have some unique challenges in our Indian scenario. I'll be showing a few of them here. Now, there's a 40-year-old lady. You can see that explantation pneumotomy specimen that we got from her during the lung transplant, where it shows bilateral bronchiectasis. It shows a post-TV cavity aspergilloma, and she also had nocardiosis. So these are the kind of inflammatory pathologies that we see in our country. She was on a home oxygen of around 4 liters. She underwent a bilateral sequential lung transplant, but the challenges in drop when we operate a patient with multiple inflammatory pathologies is the explantation pneumotomy. The explantation pneumotomies are not easy. It takes time, and they are also, especially if they have an infective pathology, they tend to have a greater chance of having sepsis post-operatively. Now, another situation here at the 39-year-old male who had bilateral bronchiectasis. And as you can see here, left destroyed lung, hyperinflation, compensatory hypertrophy of the right side. So the surgical challenge here too was, in addition to explantation pneumotomy on the left side, was that we had a larger right chest cavity when compared to a small contracted cavity on the left side. So they posed challenges as far as graft sizing is concerned, and also for volume reduction. Now, a 22-year-old patient who had had a paraquat herbicide poisoning. You can see how the CT scan looks like. He came to us in respiratory distress with acute kidney injury and liver failure. He was on ventilator by day 5 because of extensive lung fibrosis, and on VV ECMO by day 8. We waited for around 3 weeks on ECMO for the paraquat to be eliminated from his body. We did a urine paraquat level, and we made sure that paraquat was completely. The being or myopathies, and we see that he's cooperating well with us. He's obeying commands, and his muscle power is good. So he was considered for a lung transplant. So now going on to my topic proper. So how do we assess a donor lung? Now we all know that we have a significant shortage of the donor lung pool. Around 70% is a decline rate for offered donor lungs, and similarly in our institution we have around 6 donor calls per month. The average donor lung acceptance rate for us is around 33%. So that means we will as it is world over, we will also have a significant waitlist mortality and time with poor quality of life for our patients. Now, this is a paper that came out in the Journal of Heart and Lung Transplant in 2020, where they actually histologically and radiologically reassessed unused donor lungs, or lungs which are declined by the surgical team, and they found that the histological and radiological assessment showed a significant discrepancy in the clinic with the clinical reason why the lung was rejected. So we need to be particular that in a situation where we have a shortage of donor lung pool, we need to be absolutely astute as far as the donor lung is concerned for transplant suitability. I'll be speaking about gas exchange assessed by ABG, radiological assessment by X-ray and CT, bronchoscopy, in situ visual inspection, and graph size matching. Now, is there any ideal on a criteria? Now, the 2020 consensus statement for donor heart and lung procurement, which states that the donor PF ratio should be around more than 400, an ideal donor age of less than 55, smoking history of less than 20 pack years, as radiograph which should be normal without bronchoscopy secretions, absence of organisms on sputum gram stain, and no purulent secretions on bronchoscopy. So I think Professor Lawrence is about to speak about marginal donors and extended donor lung criteria. So I'm not going into that. Now, so as the first call we received, the donor apnea test and the associated ABGs, the pre-apnea and the post-apnea ABGs, which is probably the first indicator of whether the donor lung is usable or unusable. The PF ratio decided is around 300. As you can see here, one of our donors, which we accepted, where the PO2 pre-apnea was 474 and the post-apnea was 203. Now, ABO compatibility and immunological compatibility. Of course, it has to be an ABO compatible donor. We also look astutely regarding the immunological compatibility before we enter for donor lung harvesting. We do a low resolution HLA, a CDC flow cytometry, cross match, and also virtual cross match. And we mandatorily do that to predict allograft incompatibility and prevent hyperacute graft rejection. Size matching, the initial criteria which we see is a height. We height match the donor to the recipient, and the height is matching. We go on to look at the X-rays where the chest X-ray vertical and horizontal dimensions are taken, and we compare it to the recipient chest X-ray dimensions. And as you can see in the upper right corner, we have a matched lung here where the mismatch of height is around, mismatch of the vertical dimension is around 10%, and which we consider as acceptable. While we have a mismatched one lower down here where we where we see that the donor's lung is far smaller when compared to the recipient lung. So there are limitations. We know that the donor X-rays usually an AP view compared to a recipient X-ray which is taken in a PA view. So we are comparing an AP view to a PA view. It's a pretty objective assessment. If two people measure the dimensions on the X-ray, you're going to get two values. So it is a pretty subjective assessment. Now, the gold standard for objective assessment as of now is a predicted total lung capacity, the PTLC, that measures an objective assessment of the chest wall cavity size. It's calculated on the basis of a person's gender and the height. So we have the Stokes et al. Formula here for men, PTLC calculation for men and women, and based on that, we can determine whether it's an undersized graft or an oversized graft based on the ratio between the donor and the recipient PTLC of less than 1 or more than 1. Now, the ideally we want a ratio to be between 90 to 110, where the larger organs towards the 110% are considered when we have a COPD recipient, and smaller organs are preferred when we have a restrictive pathology similar to an ILD. Now, what happens if you have a gender mismatch? The female lungs are considered to be 20% less in volume than a height matched male. Now, radiological assessment using a CT is not mandatory. We may not have that luxury, especially if we are going to another hospital to have as lungs, or the donor may not be stable enough hemodynamically to be shifted to CT. And then there may be social problems preventing a CT scan from being done in the donor. So it's not a guideline, but we do tend to do that. If we have abnormalities on the X-ray, like I've shown in this picture, you see an artifact there, and there we mandatorily ask for a CT. It gives us more information on aspiration pneumonia, lung contusion, sequelae of any old tuberculosis or small tumors. Now, the donor lung bronchoscopy, which we do either preoperatively. We do it preoperatively if the donor is in house, but we tend to do it intraoperatively if the donor lung is from another hospital. So basically, they are evaluated for tracheobronchial injury, intraparenchymal bleed, and here I'm showing a video of a near ideal bronch, which we want to see. Normally, you can see the LMB has a bit of secretions, but predominantly it's clear. But here we have a bronchoscopy video where we see copious secretions reaccumulating. So we do a suctioning, we wait for a minute, and we see once more, and if we see copious secretions like that reaccumulating with mucosal erythema, mucosal bleeding and all, we tend to reject that lung. Here we have a fungal infection. It came out to be a mucor, which we saw in a donor bronch. And we also tend to have anatomical anomalies like that, the supernumerary bronchus. You're seeing there in the right main bronchus. And here also had a supernumerary bronchus on the left side, on the left side. The next video is another anatomical abnormality where you can see the right upper lobe ostia there, very close to the carina near the right main bronchus. So we tend to see these anatomical anomalies which may affect the way we do the we go ahead with the transplant. Of course, when we do a bronch, we always do a bronchoalveolar lavage and stay taken up for bacterial culture, gram staining, and then AP gene expert. Now, then once we are in the OT, once we are sure we are taking the lung, we are in the OT, we do a midline anatomy, we do a pericardial well is created, the bilateral pleural cavity is opened, and the donor lungs are inspected. What are we specifically looking for? The color, normal, like you can see over here in the top right hand corner, if it's relatively pink, we know that the lungs are good, the ABG is good, we tend to take it. Inflamed in aspiration pneumonia, we may have a lot of attenuating areas which may have to blow up. We look for the presence of any lung injury, contusion, as you can see here. And we also tend to look for parenchymal lesions, which may be bulla, nodules, scarring, and also tumors. Now, if we have adhesions, we tend to do a careful adhesiolysis. In India, we do find significant adhesions even in donors, and especially post-COVID. And if we have adhesions, we tend to do a careful adhesiolysis. We avoid injury to the visceral pleura. The possibility of air leak post-implantation is there, and we find that the air leaks, especially if caused to the donor lung, they heal poorly with immunosuppression. And what we do here is we just manipulate the donor lung gently out of the pleural cavity. We make sure the attenuating areas are re-expanded back up with a gentle valsalva. We feel the parenchyma for any scarring in nodules, tumors. If we find any peripheral nodules, we tend to do a frozen section to make sure they are benign. And then we do the elastic recoil testing, where we ask the anesthetist to disconnect the ventilator and see that the elastic recoil of the lung is good. So then after lung recruitment, we tend to get the ventilator settings to a tidal volume of 6 to 8 ml per kg, an FiO2 of 100% and a PEEP of 8 to 10. And we go on to do an ABG after 10 minutes, where we see the PF ratio. And you can see the PF ratio on this ABG is 363. Now, anything more than 300 is accepted. But if the PF ratio is less than 250, we tend to re-recruit the lungs. If there are persistent attenuating areas, we tend to repeat the bronchoscopy to remove any mucus plugs, and then maybe do a selective pulmonary venous sampling from the superior pulmonary veins. And if those values are also less than 300, and we don't tend to accept that lung. Now, donor lung harvesting, we dissect the aorta PA, we loop the innominate vein, we loop the aorta, superior vena cava, and the trachea, and I'll just show a small video here of the donor lung harvesting. So as a midline anatomy, and we tend to ligate and divide the innominate vein, and we open the retractor more widely. Then those are the pericardial stays. And once we open the pleura, we get the lung out into the midline. We assess and palpate the lung and see the elastic recoil, and if we find that it's collapsing well, we tend to feel compliance is good. That's a left lung being assessed. Yeah. And once the liver team is ready with the dissection, we heparinize and annulate the main pulmonary artery. As a perfusion cannula in the main pulmonary artery. And once we ligate the superior vena cava, PG even is given into the main pulmonary artery. The IVP, the aorta is clamped. The left atrial appendage and the IBC is vented, and we start perfusion. We give it around 4 liters of Dex plus, and we keep ventilating the lung. The lung is not stopped. We keep ventilating it, and pack the two fluid cavities with ice. So once the perfusion is over, the aortic cross clamp and the perfusion cannula are removed, and we carefully start preparing our LA cuff by entering on the left side first, and that's a incision into the left atrium on the left side, and carefully making sure we have an adequate pulmonary artery cuff. We go on to do a cardiectomy. The SPC being cut, and we go on to cut out the arch vessels and the main pulmonary artery. The arch vessels being divided, and that's the main pulmonary artery being divided. We divided around 1.5 centimeters away from the pulmonary bifurcation, and once we have it divided, we are ready to remove the heart. The cardiectomy is performed. You can see that the occur will be in the IVC to suck out all that warm perfusate fluid which is coming from the lung, and we go on to harvest the left lung, going along the aorta on the left side and along the ascites vein on the right side, and making sure we don't damage the bronchus. And once we re-recruit the athletic areas, we tend to as anesthetists to hold the lung in mid-inflation, and then ligate and divide the trachea. So we want ideally on the lung block to come out in mid-inflation, and once we have the lungs out, we take it to the back table where we divide the lung block in the right and the left lung. There was a left atrial cuff which has been divided, and now is a main pulmonary artery which has been divided into the right and the left pulmonary artery, and as the left main bronchus being divided. And once we have the right and the left lung separated, we start a retrograde perfusion through the pulmonary veins, and we watch the perfusate come out through the main pulmonary artery. We keep on perfusing until the perfusate is clear, and once 500 ml of perfusate is used for retrograde perfusion in each lung, we pack the lung and store it in ice. So we move from the owner hospital to the recipient hospital, and that's where the coordination between the recipient team and the donor team becomes important. We have in India we tend to have a lot of traffic, and we whenever we have an opportunity, we see if we can get a green corridor, so that we can reach the recipient hospital first. Now, one small problem that I occasionally see is the detection of pulmonary embolism. we tend to, when we do a retrograde perfusion in the back table, we tend to see a few clots and significant debris. So we have an article here whereby the Terada et al. Group, where they have studied for 501 patients over 9 years, where they incidentally detected PE in 22 of their donors. And they significantly noted that they had a higher instance of recipient acute cellular rejection and reduced clot-free survival. So although it's not a total contraindication, what we do in our institution is we use extra perfusate to flush out the clots till the perfusate is clear. If the ABG was good, we tend to use those lungs. Now, logistics is very important, and we have a plan of a number of team calls between the donor team and the recipient team. So what we do is, once the plan of a donor team is confirmed, the recipient is called to the hospital. The first call occurs when the donor lung is found to be suitable on visual assessment and ABG. When the recipient is taken to the OT and lines are inserted, we have around 2.5 hours to do donor aorta cross clamping if the liver is being harvested, and around 1.5 hours if only the heart and lung is being harvested. The second call occurs when the aorta is cross clamped. When the donor aorta is cross clamped, we can get the recipient intubated at that point, and the recipient is draped. We have around 45 minutes for completing the donor lung harvesting post aortic cross clamp. The third call happens when we start our journey from the donor hospital to the recipient hospital, and we are typically ready to start the recipient surgery when the donor lung team enters the recipient OT. Now, what happens if we have larger donor lungs and required? I'll not be speaking a lot about that because Dr. Lawrence is supposed to be speaking about that in a later webinar. So we use a non-anatomical lung volume reduction, which is the common technique that we use. And they are employed mainly when we want a size reduction of around 10 to 15%. We target the lateral and the posterior segments of the lower lobes and the mid lobe on the right and lingual on the left side. They are all peripheral wedge resections which are performed using the lung staplers. Now, this is the anatomical graph of volume reduction that we performed in one of our patients. She was a 46-year-old lady who had an ILD decompensation and ended up on ventilator and VV ECMO. You can see you can see how large the donor lungs were, although I have not marked it. The donor lung was around 20 centimeters tall when compared to the recipient of around 14.8. So we have it was an emergency situation where the donor had to be accepted because the recipient was already on ECMO, so we could not wait. So she underwent a non-anatomical wedge reduction on the right side, and she went on to receive an anatomical left upper lobe. We had to do an anatomical left lower lobectomy on the left side. So the left upper lobe was implanted in her, and you can see her post-op chest X-ray. One problem we faced when we did that lobectomy in her was her PA pressure tended to be high in the initial post-op period, but in a week it had come down to relatively normal values. Papers, a lot of articles are now out that clearly shows that a lobar lung transplant may have similar outcomes to a standard lung transplant. So in this era where we don't have much donor lungs, we have to start thinking about lobar or size reduced lung transplantation instead of a standard lung transplantation. Now, a few just to complete what happened to our patients that I showed earlier. Now this was the 24-year-old glass blower who had ILD and silicosis. Yeah, as you can see, a pretty bad right lung there. It is actually a stone hard lung. We had a very difficult right pneumotomy, but he recovered quite well. And that was the lungs and one happens. It was implanted by day 2. He was off ECMO and ventilator, and by day 3 he was already ambulant. And so if you take a good donor lung, a young recipient, this was a guy who was actually stuck onto a wheelchair for a few months, but after transplant he was almost ambulant by day 3. The guy who had that bilateral bronchitis, he went on to at a lung bilateral lung transplant. We had to do graft volume reduction on the left side, but we did not need to do a graft lobectomy as we thought. And you can see how after the transplant, the mediastinum has shifted back to the midline to accommodate the new left lung. And that's how he recovered by around day 5, and by day 6, right. The last patient of ours, the ECMO guy who was on Vimi ECMO for 3 weeks following a paraquat poisoning, and he went on to receive a bilateral lung transplant, and by 3rd day he was doing quite well. He was doing this post of rehab exercises. By day 4 he was on his way to physiotherapy for the intensive physiotherapy. So in him, because he had a VV ECMO, we put in an aortic cannula. We converted into a AV ECMO intraoperatively, and then back to VV. He came off ECMO on day 1 and off ventilator on day 2. So a small slide that I like to share the big 5 institutions in lung transplant data from 2014. You can see that all the big 5 are doing around 100 plus transplants in 2014. Way back in 2014, around 10 years prior, Germany, Vienna, Austria, Canada, Ohio, US, University of Pittsburgh. So I really feel that we in India are poised to take our lung transplant programs ahead, and if we can land a lunar module on the moon, I think we are really ready to take our transplant programs, lung transplant programs, to the next level. Thank you so much.
Thanks, Dr. Balasubramoniam, for the extensive presentation about the ways about the different steps about the donor lung harvesting and what are the practical difficulty. So how we thought this presentation to go about is, first we'll, when Dr. Bala sir spoke about the, he's told about his steps, we thought next we'll ask Professor Ceulemans about his inputs regarding to this topic, because as you know that there will be some differences in opinion, and there will be some new points that which both of us can learn, and we can also improve our program. So over to Professor Ceulemans to share his insights about the above topic.
Thank you very much, Dr. Varghese, Dr. Balasubramoniam. Thank you very much for your interesting presentation. I have to congratulate you both, because if I see these indications, they are quite challenging. Indeed, these are stone heart lungs. These are not the easy COPD lungs. So if you can build a successful program in such challenging cases, then if the COPD lungs will come, and they will come, you will have great results with them. So congratulations for that. I understand if you start building a program that you stick, of course, to the ideal criteria donor lungs, which you perfectly illustrated and visualized what are perfectly ideal lungs. However, if you say that you indeed accept or consider lungs with some pulmonary embolism, as you should do, and I think you follow the right strategy to flush out these pulmonary embolisms, then you can perfectly use them, and we do the same. We make a difference between what's an old embolism and what's a new embolism, and you can clearly see that on the back table, what is a fresh clot and what's an old clot. And if there's a fresh clot, if it's out, and you can use them. I'm happy to share some of our findings. I'm going to share my presentation. Please confirm me if you can see my slideshow.
Yes, yes, we can see.
Okay, so I would like to share some experience from our center regarding donation after circulatory death, which is considered also as an extended criteria donor in most part of the world. And then I would like to share some recent innovation that we implemented in our hospital and that changed the complete field of our lung transplant program. And that is a different way of preservation, leaving the ice age behind. I would like to thank you, first of all, Dr. Vaghese and Dr. Balasubramoniam, for the very kind invitation to share our experience. And I recall Dr. Vaghese being at our hospital, almost becoming a lung transplant surgeon because he was so passionate and motivated to learn all the tips and tricks. And we had a fantastic time together in Leuven, and I recall that with very good thoughts, Dr. Vaghese. And I give this presentation on behalf of the Leuven Thoracic Department. The Leuven University Hospitals is one of the largest academic hospitals in Europe with more than 3,000 beds. We cover all possible diseases, and it's linked to one of the oldest universities in the world. It's the Catholic University of Leuven, which celebrates next year 600 years of existence. And you're all more than welcome to visit us one day. So with our Department of Thoracic Surgery, we cover all aspects of the chest except for the heart. I myself, I am responsible for the lung transplantation and for the lung volume reduction surgery for end-stage emphysema patients. I support the general lung surgery. In our department, we also treat more than 250 esophageal cancers per year. And I'm also responsible for mesothelioma surgery and mediastinal tumors. But besides that, our department covers patients with chest trauma, tracheal diseases, congenital, etc. And then I am indeed the head of the lab of our basic research on lung transplant and thoracic surgery. What we have implemented over the last years is a mice lung transplant model. Here you see one of my PhD students, Jin Xin. He's coming from Beijing in China, and he's doing a mice lung transplant to study the immunomodulation, trying to unravel new mechanisms to overcome the immunosuppressive hurdle. And here you see another PhD student of me who is doing some rat ex vivo lung perfusion. We can maintain rat lungs for 7 to 8 hours ex vivo on this module. And what we are currently doing is genetic modification while being ex vivo lung perfused and ventilated, and then transplant them afterwards. And we hope to bring these insights into clinics in the next years. So what the presentation itself is about, it's about sharing insights on the procurement of extended criteria donors and on the preservation. There are two types of donors, and while I was watching the videos of your experience, this was, I think, a brain dead donor because the heart was still beating, which is the classic donation process. But also in Leuven, we have built large experience with donation after circulatory death. These are two types of donors. Donation after circulatory death, or patients who can be classified in 5 different categories. main patients or the ones who are the controlled donation after circulatory death, which are the DCD 3 types. We also have a legal framework in large parts of Europe for DCD 5, which means that we can procure the lungs after euthanasia, after the patient is declared dead. And we embraced this donation after circulatory death because over the last 15 years, it's more rare and rare to find the ideal donor in Belgium and Europe, because changing traffic rules have changed in that way that we rarely see a young donor with an isolated craniocerebral trauma, and we more and more only see older donors or donors after circulatory death or donors with a pneumonia. And so we changed from the ideal donor in the end of the 90s, beginning of 2000, to now the more extended criteria donor. In this slide, you can appreciate our experience with lung transplantation in Leuven. We did the first one in 1991, and since then we have almost done 1,500. And in the gray, you can see that the proportion of donation after circulatory death becomes bigger and bigger. Last year, we almost did 75 transplants, and 40% of them were coming from donors after circulatory death. What you can also see here is that in 2012, we did more than 80 transplants, and then in 2020, you see a small drop, which was due to COVID-19 because of logistic restrictions. And only last year we came out of that drop, and we are now getting back to our normal volume, which is one of the largest in Europe. Regarding donation after circulatory death, there come a few aspects into account, and one very important aspect is that you create 3 different independent teams. You have one team who's taking care of the patient, who is not a donor yet. There's one team who's taking care of the potential donor organs, and then there's one team taking care of the recipient, and there shouldn't be any interaction between these teams. So what happens is that you have a potential donor who is a patient with an in-force prognosis, mostly after a severe cerebrovascular accident, who is dependent on mechanical ventilation. This donor is brought to the operating theater, and there the mechanical ventilation is stopped. These are patients in whom it is anticipated that if you stop the ventilatory support, that these patients will develop a cardiac arrest and will die afterwards. There, the trick is really to estimate and anticipate very well which patient can become donor. So they're brought to the operating theater, they're installed like for a normal operative procedure, and then the surgical team goes out, and only the anesthesiological team and the neurologists stay with the patient. The mechanical ventilation is stopped, which means that the patient is extubated. Also, the medication that is supportive for the patient is stopped, and then we see what happens. And in most instances, the patient stops breathing and develops a cardiac arrest. After 5 minutes of cardiac arrest, we come in and we can start the procedure and still procure lungs, liver, kidney that can be used successfully for transplant. 5 minutes after the cardiac arrest, 3 independent physicians sign that the patient is dead and declared dead, so that we can procure these organs. Here you see how the donor is completely prepared. You can see that already like in the setting of donation after brain death, that everything is ready for perfusion on the bench. All instruments are installed. And then I share some videos how this goes. So there are 2 teams. There's the abdominal team and the thoracic team. And here you see that there's a complete sternolaparotomy. At this moment, the patient is dead. He's a donor, and the heart is not beating anymore. So we need to be fast to make sure that there's not too much damage caused by warm ischemia to the lungs. This was one of our fellows in training who is here now doing the sternotomy. As you can see, we cut with the scissor into the sternum, and then we use the saw, which we will see in a moment, to open up the sternum. In the meantime, the abdominal team is opening the abdomen. Here you can see we're doing a sternotomy from the cranial to the caudal side. It was the first time for this fellow, but she did really well. And then we open up the chest. In the meantime, the abdomen is open, and you will see the heart there in the pericardium, which is not beating anymore. You can see was a small mistake, but corrected. You have to put a spreader, of course, not in the way of the abdominal surgeons. And then the goal is to perfuse the lungs as soon as possible to limit this warm ischemia damage, and of course to vent the left auricle so that it's not only perfusion, because then you would have a swelling of the lung. So before we perfuse, we cut open the inferior caval vein and the left auriculum so that the perfusion solution can run out. Then we look for the pulmonary artery or the right ventricular outflow tract. We open it up. Here you see how we cut open the pericardium in a Mercedes-like fashion. And over the last years, we also embraced the technology of normothermic regional perfusion so that these hearts can be used for transplant as well. And we have done several cases now. However, there's still an ethical dilemma going on now to make sure that with the restart of the regional perfusion, there's no reactivation of the brain. But we did several cases, and it will definitely be a future step for donation after circulatory death. Also, these hearts can be procured and put on the machine for evaluation. And of course, this expands the heart donor pool as well. As you can see here, we open up the pulmonary artery. As you can see, we continue because not too much time should be wasted, because these moments the lung experience ischemia. However, as you can see, we restart ventilation so that the oxygen can protect the lungs. And there we open up the pulmonary artery. As you can see, the blood flows out, and then we put in the cannula and we start the flush after administering prostaglandin, which will help for vasodilation. What's also important is that this moment we really recruit the lungs well, so that you have maximum vascular bed, so that the flush is well performed. It's not good to do a flush on atelectatic lungs, as my colleague also mentioned during his presentation. And also in these cases, we perform a bronchoscopy up front, and we also take our bronchoscopy, which is just a small video screen and a single-use bronchoscope. We take them to the donor hospital so that we can always do the bronchoscopy. And here you see how the lungs are nicely perfused. They are white, and then we take them out in the same fashion. We staple the trachea while the lungs are well inflated, and then we cut the trachea and we take the lungs out one by one, preventing any tearing from the parenchyma, which could cause a deflation over time. And here you can see that the heart lung block is taken out. This should not take more than a few minutes. And then also here we split the lungs so that they can be preserved separately. And because we do a sequential single lung transplantation while transplanting the first lung, the other lung can still be well preserved and is not lying there on the bench table of the for the recipients. What is really important is that we do a thorough assessment of these lungs and distinguish between lungs which cannot be accepted and perfect lungs. However, a large part of these lungs may be in between. These are the extended criteria lungs, which are lungs with maybe a moderate PF ratio, maybe lungs with small pneumonia and infiltrate, lungs of patients who smoked before, lungs of patients with a high age. Over the last 10 years, we really developed a good sense of what are marginal lungs, which are still good enough for transplantation. And that is just because we don't or rarely see that ideal donor. So I always tell my fellows that it is a bit, the most difficult part, it's not the surgery, it's the evaluation of these lungs. And there are several factors that you need to take into account. A very important message, however, is that this decision is not made by the donor center, but that if there is a potential donor, regardless of the quality of the lungs on paper or on chest CT, that they call to our transplant center, that we do a first evaluation on paper, we look at chest CT, but in most instances, we send the team out to evaluate the lungs on the spot and make the decision there, regardless of some criteria which may not lie within the ideal donor criteria, which means if you see a small pneumonia on the chest CT, or you see a bilateral atelectasis on the chest CT, or you have a 94-year-old donor like we had 2 months ago, we go out, we check the lungs, we do a FaceTime evaluation with the transplant surgeon, and then we decline or we accept, and we take also into account the status of the recipient. If it is a patient who is home with COPD or fibrosis for a year, who's quite stable, in good general condition, he or she can handle maybe a small pneumonia or some scarring from the donor lung. Of course, we will not give donor lungs of an 81-year-old to recipients with cystic fibrosis of 20 years old. So we also take the status of the recipient into account. In regard to lobar transplantation, it's a fantastic procedure, and it's an important procedure to expand your donor pool, but be aware, if you want to implement that extra criterion, which makes it more difficult and more challenging and more risk by doing a lobar transplant, these donor lungs should be of perfect quality. Don't make any compromises in that setting. Here you see a recent paper that was published in the Annals of Surgery, the most important surgical journal, where we evaluated and performed an actual propensity matched analysis of our lung transplant outcome from donors older than 70 years with younger donors than 70 years. And we had more than 60 donors older than 70 years, and we did a thorough analysis with the primary endpoint being survival, and there was no difference. What we found in our retrospective analysis was that we were more selective in older donors, which were mostly female, but we went on to the donor centrum, we evaluated thoroughly, and if all criteria were well, then we accepted these organs. So I think every criterion that's mentioned there in the list of my colleague should be evaluated on the spot. And you can have some compromises on some criteria if the other criteria are excellent. So this in regard to our lung procurement experience, which differs from your experience at this stage. What really is very interesting is what happened over the last year at our center, because a whole new era of lung preservation has dawned, and we are writing some papers on that. Some reviews will come up later this month. Since the beginning of lung transplantation, the field has been challenging for the surgeons in regard to primary graft dysfunction, which means that immediately after the transplant, within the first 72 hours, lungs can become very edematous, and patients need to be on prolonged ECMO to overcome this first phase of edema. And since the beginning, surgeons have tried to modify different settings between the harvest and the transplant to optimize and reduce the risk of primary graft dysfunction. For example, in the donor, every center now performs a retrograde flush and lungs remain inflated during preservation. We changed from static ice storage over normothermic ex vivo lung perfusion to now the status of static controlled hypothermic preservation. And then in the recipient, I also refer to a paper from our center where we have shown that the faster you implant the lung, the less warm ischemia the lung will be exposed to, and the less primary graft dysfunction you will see. An important message that I would like to bring is that static cold storage means storing lungs on ice, and ice is not 4 degrees of Celsius. However, in most literature, it is referred to 4 degrees of Celsius. We have understood that cold ischemia is not 4 degrees of Celsius, and over the last years, we have actually measured this temperature in our clinical lungs, both the core temperature as well as the surface temperature, and lungs stored on ice were more around 1 degree. We should also appreciate that lungs, in contrast to, for example, liver and kidneys, are very unique because cellular metabolism can continue during the preservation in the absence of circulation because we have two balloons filled with oxygen. This was a statement by the lab from Joel Cooper already in the 90s, when they found that lungs preserved on 10 degrees outperformed lungs preserved on 4 or 15 degrees. After an extended preservation time of 24 hours and an evaluation of post-preservation lung function in a rabbit model, they found that both the PO2 immediately after perfusion of these lungs, as well as the PAP, were better after the 10 degrees versus the 4 degrees preservation. And not only immediately after this preservation, this was confirmed up to 3 days after reperfusion of these lungs. This is data from the beginning of the 90s from the lab of Joel Cooper. And this old evidence was readdressed quite recently also by the team from Toronto, by Marcelo Cipel, and this was presented in this Science Translational Medicine paper, where they kept lungs either on ice or preserved on 10 degrees and then for 36 hours and then evaluated them with ex vivo lung perfusion. And one of the mechanisms they found out that was that static ice storage actually causes cell injury and will lead to mitochondrial damage. Preserving lungs on a temperature more like 8 to 10 degrees better preserve this mitochondrial health. Actual mechanism of action is that there is at these 10 degrees, there is maintained a balance between the cellular metabolic needs and the actual oxygen consumption without the freezing injury that is caused by ice. So you have less mitochondrial dysfunction, and you have also an accumulation, it was also seen, of cytoprotective mitochondrial-related metabolites. And then several devices are currently being studied or on the market. You have the classic cooler, ice cooler, which is non-transportable and used in the first clinical experience of Toronto. Then used in a randomized clinical trial now is the Export Traferix from Toronto, which keep lungs at 10 degrees. Then you have the one that was first on the market, which is the LungGuard from the US company Paragonix that we actually use now in our clinical setting and which is FDA and CE marked. And then you have the VitalPack, however, that temperature is lower and mostly used for abdominal organs. Here you can see the chest X-rays published in Science Translational Medicine of the first 5 patients where the lungs were preserved at 10 degrees overnight, and there was no PGD3 at 72 hours. And then there was a study between Toronto, Madrid, and Vienna, where they compared 70 lungs, where the lungs were preserved overnight at 10 degrees with 140 historical patients. One remark here is that the lungs were still transported to the recipient hospital on ice, and that transport took 3 hours. And during these 3 hours, of course, the lungs decreased onto 0 to 1 degrees. So what they found out was that there was a tendency towards having lower PGD3 at 72 hours. But what was most important and most remarkable was that these lungs did even well after bridging the night. And then this LungGuard, which was brought to the market by Paragonix, is now tested in several centers in the US and also in Europe over the last year. And what they found in their post-market registry analysis, and they presented last year in Denver and in Los Angeles during the AATS, was that also there was a tendency towards lower PGD3 at 72 hours. And although the lungs were preserved longer, the outcome was similar to static ice storage. And so based on this, There's now a randomized controlled trial going on, led by Marcelo Cipel from Toronto and Konrad Hutzenecker from Vienna, and Leuven is also participating, where we compare 160 patients preserved on ice versus 160 patients preserved on 10 degrees. And if preserved on 10 degrees, the lungs are allowed to be preserved for more than 12 hours. And we expect results in 1.5 years from now. So with the LungGuard on the market since January 2023, our policy in Leuven has changed. When we have a donor where the cross clamp is after 6 or 8 in the evening, a team is going out to procure the lungs, bring them back in that device of that static controlled hypothermic device of the LungGuard, keeping the lungs between 6 to 8 degrees. We keep them overnight in the head nurse office, and then we start with the transplant at 7:45 in the morning. This overcomes, of course, several logistical limitations also. For example, when we are transplanting one lung, we can already send a team out to evaluate the second lung because we know, okay, we have time to finish the first lung because these lungs are preserved longer safely. And we use this box also to accept really extended criteria donors. For example, in September, we accepted a 94-year-old DCD donor, which is the oldest recorded lung transplant donor in the world. And of course, this is lungs that really need to be taken care of under the best conditions. We have done over the last year 17 transplants where the lungs were preserved on LungGuard with a median age of 56 years old. Most important indication was COPD. I can tell you that half of our lung transplant patients are for COPD, followed by ILD or vascular indications. And then the indication to use the LungGuard was mostly to bridge the night or for some distant procurement. 5 out of these patients needed ECMO, mostly due to indications like, for example, pulmonary hypertension, because the strategy is in Leuven to perform sequential single lung transplant without ECMO and only reserving ECMO when there is a ventilatory or a cardiac need during the procedure. The average LungGuard temperature during preservation was 6.8 degrees, and the ischemia time of the second implanted lung lasted even up to 22 hours. That is, of course, because we bridge the night. PGD3 within 72 hours was 35%, which is equal to our historic cohort. And at 72 hours, like in the previous studies, we didn't see any PGD3. Length of hospital stay was around 30 days. There was also some high-risk recipients included in this cohort. And then, for example, you can see while the lungs are stored in the device, we can follow the temperature on an app on our iPhone over time. For example, here you see a case that was performed a few weeks ago where we had an ischemic time of 16 hours, 51 minutes. This night bridging, and I'm coming to the end of my presentation, introduces flexibility. Flexibility in a setting of transplant is something that is really valued a lot. Flexibility without compromising outcome has different benefits, not only for the patient, because we are investigating if this controlled hypothermic storage also outperforms the lungs stored on ice, but also for the transplant team itself. There are several benefits. We reduce the time pressure and improve the objectivity of the procuring surgeons. We have a fit team, which will reduce the likelihood of errors. The best team is available during the day. We overcome logistical limitations. We have more expertise during the daytime, and it also improves the attractivity of the profession. And you might even think about transcontinental exchange of organs in a setting where you can go up to 24 hours of safe preservation. So how does that leave ex vivo lung perfusion? I think EVLP can still be used for reassessment of questionable donor lungs. However, that need in our center is not that big because we have developed over time a very good sense of what is an acceptable donor lung, but this indication will remain. The prolonged preservation of healthy donor lungs will not be an indication anymore because now we have this controlled hypothermic storage. but the real value of ex vivo lung perfusion in the future will be in allograft treatment and modulation, maybe by gene therapy, maybe by cell therapy or other biologicals. And therefore, we will need this ex vivo lung perfusion. So the future is towards a new standard, away from ice preservation. We will go into an era of prolonged preservation, and we have to understand in the next years if it's really safe to bridge the night. What will be the ideal temperature? Can we actually reduce primary graft dysfunction and improve survival? Long-term outcome has to show that. What's the actual mechanism? And is this really protective also for extended criteria donors? I would like to thank the whole Leuven team who is helping to build our lung transplant program. And I would like to thank the chair, Dr. Vaghese, and my colleague, Dr. Balasubramoniam, for the kind invitation.
Thanks, Professor Ceulemans, about the new inputs as regard to preservation. I think everybody thinks, even in our center and probably many of the places, that put more lungs when there is a donor lung and take the lung as soon as possible. So I think these are the few sessions which gives an insight which makes us to change our practice, and we learn a lot by the new inputs from your center. Now, I'll just see whether if any questions are there, or otherwise I'll ask Dr. Bala if he has any queries as regard to this.
Yeah, so thank you, Dr. Ceulemans, for the excellent talk. Really heartening to see that lung transplant is becoming an elective procedure soon. Like if you can still go bridge the night, we can actually perform lung transplant as a elective procedure in future. Now, we in India, we do not actually have a legislation for DCD donors. So we don't have any experience with DCD in India, although I think we may be having a legislation coming up soon. Then the second thing was, is LungGuard, is it available world over? Because we are now using ice for a preservation. We would also like to move on to the end degree normothermic. So is that the only company available, or do we have more options?
So for now, so to answer your first question, I think it would be very good if there would be coming a legislation possible for accepting donation after circulatory death, because this has really expanded the potential donor pool. What is important in that setting is that if you can keep that agonal phase between withdrawal of life-sustaining therapy and the removal of the organs, if you can keep that short, then there's no question that for lungs the results are equally good to donation after brain death. It has been shown several times in large registries, and it's our own experience in Leuven as well. There's no doubt. But your agonal phase needs to be maintained short, which means within an hour, something like that. Okay. And then regarding DCD itself, I don't think you should assess it as an additional extended criteria or a marginal donor. I think DCDs can be equally good also from older donors. As you heard in my presentation, this 94-year-old donor had DCD lungs, and the patient was home within 3 weeks after transplant, doing very well. What we do have to understand for older donors, it's what's the impact of this age on the recipient, and for that we are doing some researches in our lab. Regarding the LungGuard is a device. The name comes from a company. It's Paragonix. It's based in Boston in the US, and so they brought it on the market a few years ago. It's on the market in the US, it's on the market in Europe, and I know that a few months ago there was performed a transplant in Iran as well. So I think that if you can contact the company, they would be interested to see what's possible in India. What I know from Toronto is that they are developing their own device, which is the export from Traferox, and that is used in a randomized clinical trial right now. And then I also know that, for example, the Vitalpac, which was based in France, is also used for lungs in France. So over the next years, we will see an increased interest from several companies around the world. And there's no doubt that in Asia and India, you will have access to these devices as well. Okay.
So when you use the lung guard, how do you pack your lungs? Like when we use in ice, you have it in a bag with perfusion fluid, and then a second bag, and then you have ice around the second bag, and then you have a third bag. So,
so it's exactly the same. It's exactly the same. 3 bags. The middle, the inner bag is just preservation solution, 1 liter. The second bag is cold water, but no ice, cold water. And then the third bag is just a sterile bag. And on the bench, we use 250 cc of ice around the bag in which the lung block is laid, but not more than 250 cc of ice, because we don't want to cool the lungs down to 0 degrees and then warm them up again. So we keep them around, and we measure that, we keep them around 10 to 15 degrees on the bench. We don't do a complete bench, we just do a split and we pack them, and we do the bench at the recipient hospital. Otherwise, it might take sometimes, if you have an inexperienced procurement surgeon, it might take too long for the bench and the lungs will warm up or really cool down a lot.
So you don't do retrograde perfusion in the owner's in the donor hospital.
Yes.
You do it in the recipient hospital.
No, we do it in the donor hospital. So after we take out the lungs, we split them, and then we use 1 liter of preservation solution for retrograde flush. And I'm thinking now to also maybe do it in the recipient just before implantation, just to flush out all the waste that was built up during preservation. That could be an interesting thing to investigate over the coming months to see what's the added benefit of doing a second retrograde flush.
Okay. Thank you.
I think there are no questions from audience, and I think it's already 8 past 15 minutes past 8 o'clock. So thank you everyone for the excellent presentation and excellent input as regard to this topic, which will change our practice. So this webinar is a alternate weeks exclusive educational webinar as regard to heart and lung transplant and the different topics involved. So stay tuned for the different weeks about the different topics, which will be really interesting, and experts from the different fields will be presenting. Thank you, everyone. Good night.
Thank you so much.
Thank you. Thank you very much.